At this point, I would like to introduce to you Dr. William Dillon. He is the Elizabeth A. Guillaumin Professor of Radiology and Chief of the Division of Neuroradiology at the University of California, San Francisco School of Medicine in San Francisco. Welcome,
Thank you.
Dr. He's going to be talking about imaging over the last 30 years.
Decades. Thank you. Thank you very much. Thank you. Okay, well, thank you very much. I've learned so much already this morning, so I'm hoping I can bring a little bit more interest to this topic for you. My topic was assigned to me over the last 30 years, and it just means that I'm old. But I have started, in 1990 or 1991 or thereabouts, dealing with patients with CSF leaks and SIH, and it's been an incredible experience for me. Very humbling, I must say. Anybody who takes care of these patients really has to commit to taking care of them, and almost like primary care doctors in many cases. And I will say that my job has gotten as a neuroradiologist harder and not easier. And it's largely because a lot of the easy cases are taken care of now. The diagnosis is made out in the community. A blood patch is applied. The patient's just fine. And I remember one of my kid's schoolmate's mother who was, a note was sent around, and the note from the school said, can people bring food to Sue? She's got viral meningitis at home, and she'll be out for 2 or 3 weeks. And I just thought that was kind of weird, so I called her up, and she said, I had the weirdest thing. I had this onset of headache on this particular day. I can't remember which day it was. And I can't get out of bed. The headache is terrible. And I said, well, I know what you have. You don't have viral meningitis. She had a little high protein and lymphocytosis, and they made the diagnosis of viral meningitis, but it wasn't. It was SIH, and a blood patch cured her very easily. So that's the easy ones now that are taken care of in many places. The harder ones that we get now are these patients whose leaks are recalcitrant or difficult to see, and yet we know that they have the syndrome, and that's hopefully what I'm going to talk a little bit about today. So I have to give homage to the late Robert Fishman. He was our chair of neurology for many years, 25 years or so, and he got me involved in these patients, and we had a wonderful team approach for several years. And one of the very early reports in the 90s was one that we did together, demonstrating the reversibility of dural enhancement and the SAG that occurred shortly, I think, after Mokri at Mayo Clinic reported his cases. So there was a flurry of cases in the 1990s, and it became very clear that this was a syndrome we were missing as neuroradiologists for many years. I mean, I don't remember as a fellow ever making this diagnosis. At the basis of the and you've heard a lot about this, of the neuroradiologic findings is this concept that the total volume within an intact skull, and that's an important one because if someone's had a craniectomy, it doesn't apply as well, is constant. And this is the so-called Monreal-Kelly doctrine or Monreal-Kelly rule. If the CSF goes down, something has to take its place, and that's usually very early on dilatation of veins and dural sinuses. So Dr. Farr, back in the back, reported the venous distension sign in 2007, and here's just an example of a patient pre and post blood patch, successful blood patch, and you can see that the transverse sinus is rounded. Normally it's within a dural sleeve that's triangular, and after therapy the patient not only lost the dural enhancement but also the venous distension disappeared. And this can happen very rapidly over the course of 24 hours, and it's a very nice sign. And I look for that venous distension sign throughout the veins, but particularly in the sagittal plane in the transverse sinus. I think it's a nice sign to look for. So we've heard a lot about the etiologies, and I won't go into great detail, but of course a ruptured cyst, or perhaps it's a dural a transgression of the dura by disc herniation. We do see these sometimes in the ventral area as as Dr. Shiving pointed out, and these are better seen on CT. So I want to make the point that you can easily miss these shards of bone on MR, even good quality MR. We do see it here on this particular case, but I have many cases where this little shard of bone is not seen on MR. And this was a nice case report of a patient who responded after surgery to this transdural herniation and osteophytic spur. Then, of course, the venous and/or lymphatic fistula. The CSF can communicate with veins as well as lymphatics. And, of course, we can have connective tissue disorders, as has been discussed. And here's just an example of one of the venous fistulas that you can sometimes detect on CT or on myelography. Now, what are the findings? We've talked about this dural enhancement, and Dr. Shiving pointed out a pitfall, and that is leptomeningeal disease. This is, as Dr. Fishman pointed out to me, as if a felt pen was taken around the dura, right? So it doesn't go into the peel surfaces. It's on the dural surface itself. It is usually and typically diffuse, both in supratentorial and infratentorial compartments. So someone with, for instance, breast carcinoma metastasis or lymphoma can have a similar feature, but it usually is segmental, and or breast metastasis, for instance, to the calvarium may involve the dura, but segmentally. You can see pachymeningitis in some of the collagen diseases or the inflammatory diseases such as Wegener's, but again, this is usually segmental and not diffuse. The brain sag, let's talk a little bit about that. So along with descent of the tonsils, very often you'll see descent of the floor of the third ventricle as shown here. And this is a great feature that is really seen with intracranial hypotension. It can be seen with intracranial hypertension, I'll make that point, but it's not seen usually with Chiari 1 malformation. So I think it's a nice way to discriminate those two. Otherwise, it can be very difficult. Distension of the veins both occur in the brain, intracranially, as well as in the spine. Sometimes this has been misinterpreted as tumors or meningiomas. So here up by C2, you can see these very, very prominent veins that have dilated. And you can see intradural venous dilatation as well. We've had several misdiagnoses of purported AV fistulas simply because of dilatation of veins intradurally looking like an AV fistula. Someone mentioned pituitary, the pituitary prominence. This is a reason for misdiagnosis, and we've had several patients come to us with pituitary surgery preceding their diagnosis. And patients are usually endocrinologically normal, but have this prominent pituitary, presumably from, again, venous dilatation within the pituitary gland, which is outside the blood-brain barrier. And, of course, you can then imagine the effusions and hematomas that can occur with protracted loss of CSF volume. Finally, the midbrain compression and temporal lobe compression, and I've actually seen edema within the midbrain. This may be a cause for some of the cranial neuropathies that you've seen. These are patients that can sometimes present from the memory and aging clinic. We've seen several developing either stupor, coma, or mental disorders, and it looks very similar to the Chiari 2 malformation, doesn't it? This heart-shaped midbrain. And when you think about it, Chiari 2 with the meningomyelocele is probably in utero SIH. Siderosis. This occurs predominantly and rarely in the posterior fossa. There are other causes for siderosis. Ependymomas of the spinal canal, for instance. But I've seen now, maybe a dozen patients presenting with the deposition of hemosiderin in the posterior fossa, particularly along the cerebellar folia and vermis. Very often these patients have like a pseudomeningocele, a cavity that has been formed by their leak and develops perhaps granulation tissue, or perhaps there's a communication with veins producing this back and forth chronic blood deposition within the subarachnoid space. Okay, so once the clinical possibility of SIH has been raised, now what? So this is where we get involved. We do all of our blood patches under CT guidance, and here you see a needle going into the epidural space, and we put a little contrast, usually 1 cc of contrast in 9 cc's of blood, and that's and then we inject slowly, usually five or so mils of aliquot, making sure we're not compressing the thecal sac or causing a mass, and we'll just continue up to about 20 to 30 cc's if the patient tolerates that. And we'll do this non-targeted at multiple levels in the thoracic and high lumbar spine, typically maybe at T3-4, T7-8, down around T12-L1, because we want to try to get the distribution of blood through the thoracic spine, which is where most of these leaks are occurring. And it's my opinion that just simply a lumbar blood patch rarely works. It doesn't really go up to where we want it to go. We'll sometimes put the patient in Trendelenburg or what have you, but I just found that doing multiple blood patches non-targeted, first off in a patient with SIH, and a lot of those will respond to that, and I don't have to do a lot more on those patients. So if they don't respond, then we seek the leak, if you will, and we do that with myelography, either conventional myelography in the decubitus position if we're concerned about a fistula, or CT myelography in the prone position, or in the decubitus position, again, if we think there's a fistula, as you can see here. Non-contrast MR myelography done with FAT-SAT is probably the first thing we'll do in patients who we suspect having a leak, because we're looking for extradural CSF in those patients, and that'll determine how we then approach myelography. And on occasion, we've had the reason to do MR myelography with gadolinium. Now, we don't do this very much. We have reported this in the past. It's probably used only rarely in patients who either everything has failed and we know this patient has a syndrome, or we're looking for a very, very slow leak in a maybe hour, 2, 3 after injection. And this provides us a way to see those patients. It's very sensitive to leak. You'll see where your puncture is. You'll see a little gadolinium leaking out, potentially also out through the extradural space. You have to be careful about misinterpreting that and look for gadolinium leakage up in the thoracic spine. So we have used this. We don't use it very often. Okay, so CT can show a shard of bone that MR does not, and here's an example where we have the typical extradural dog ear, as Dr. Fishman used to call it, over the ventral aspect of the thecal sac, and a small shard of bone, as Dr. Shivink also pointed out. And I think that this is very, very important to look for. It's increasingly the reason for these ventral leaks that we see. We used to think of transdural herniations as being very rare. When I was a fellow, we hardly ever saw them. Now I think they're much more frequently a cause of intracranial hypotension. Some of the patients that I recall having this, they almost always occur at a difficult location up in the high thoracic spine. Yoga, shoulder stands. We've seen several patients with that. So, if you're a yoga advocate, I would highly recommend that you not participate in shoulder stands, because it's just putting tremendous pressure at that location ventrally. Okay, if you have a rapid leak, or if you have CSF that's seen extradurally in the spine on your scan, then you're really dealing with, and the whole idea behind neuroradiology is to tell our surgeon precisely where to go. That's how I always teach our fellows, look, if you're going to send someone to surgery, you better be really sure, okay, really sure where it is. Don't just be sort of sure, and if you're not completely sure, you've got to do something else to be really sure. And I think the neuroradiologists in the audience have learned the lessons over time that And I'll show you a case of my errors where, I thought I was sure, but I wasn't 100% sure and made an error. So rapid localization of leaks is, as you've seen, done by myelography. It can do it also with CT. Here's an example from the literature. One of our ex-fellows, Joe Hawksworth from Mayo Clinic down in Arizona, first reported the use of this in the sagittal plane. It does help that a leak is in the ventral aspect. Otherwise, you might obscure it. So it does. It's a nice technique, but I prefer CT if I can get away with it because it might demonstrate where this leak is a little bit more clearly than on myelography. But they're complementary. Okay, GAD. You only have to put in about 0.2 to 0.3. 0.2 to 0.3, sometimes people would use a little more, of GAD into the CSF. And why would we do this? Again, here's an example where you have a very slow, subtle leak from a perineural cyst, which is, I think, difficult to see on CT, certainly immediately. And so I think that there are some cases in which this is helpful, but it's few and far between. Okay, another example where GAD was placed in a patient with Marfan's who had this sort of reservoir-type syndrome where when they stood up, they developed postural headache, and you can see that there's some effusions on this CT scan. It almost looks like he's got herniation syndrome in his midbrain. And you see this classic dural ectasia down below, and there's a cyst that's not filling, and cysts and lateral meningoceles that are not leaking. And we didn't find a leak in this patient, even initially. However, they came back 7 hours later for an intracranial study, and they had leakage of gadolinium in the extradural space, which indicated to me that there are some patients with either paper-thin dura or perhaps another type of fistula where the leak may actually be so slow that an immediate scan may not see them. And so, again, this is one reason why you might consider using gadolinium. Obviously, this is off-label use. Okay, so our sort of approach to this is that if a patient comes to us and is suspected SIH, we do a brain study with contrast, and we do a fat-suppressed study of the spine in the axial plane, T2 weighted. And we're looking there for extradural CSF. So if there is extradural CSF in the spine and the brain is positive, then we'll typically go on to, and we might do a blood patch at that point, but if that's not successful, we would go on to a dynamic myelogram, usually under CT, or under fluoro with the patient prone. But the idea behind this is most likely this is going to be a transdural or perineural cyst rupture, and we'll be able to see that in the prone position. If the spine is negative, that is, we have SIH, but there is no extradural CSF seen on that study, then we'll usually go on to a dynamic study in the a decubitus position, as already been mentioned. And I think that it is true that we can see more of these CSF venous fistulas in the decubitus position. This may require, though, that you bring the patient back for one side and then the other, or maybe low and high. So my message to the patients when they enter, this process is that it is a process. We're not going to diagnose. We may not diagnose you on the first study. It may take multiple studies and multiple blood patches, but you have a curable disease, essentially. There are a few that are still out there that are the tough ones, and probably many of them are next door, but. These are patients you have to reassure, but it may be a process. So if there's no spinal collection seen on that decubitus study, we may then augment pressure using sterile saline and a pressure monitor. And so I've had the occasion where we use these little digital manometers, and we will inject 5 cc's of sterile saline, measure the pressure. Then if it starts rising, go down to 1 cc and get it up to in the 20s, then give contrast. With the idea behind this is to augment the pressure so that we make any visible leak more visible. So the prone position helps us with osteophytic spurs. The decubitus helps us with the CSF venous fistulas. And intrathecal saline in our hands helps elicit leaks on occasion in patients with very low CSF pressure. If the brain imaging is negative and there's a high clinical suspicion for SIH, myelography should still be performed. Remember, brain imaging can be normal in some of these patients and up to 20%. So let me show you a few interesting cases over the years that I've seen that I couldn't bring all of them, but one pitfall is that intracranial hypertension can look very similar to intracranial hypotension. So sagging and descent of the third ventricle can be seen in patients with intracranial hypertension. Okay, so don't make that mistake. Look for dural sinuses. They are dilated typically in hypotension and effaced in hypertension. This is a patient who has hydrocephalus and had cysticercosis. Because of cysticercosis, developed hypertension and was already herniating downward, and it looks for all the world similar to SIH. It goes without saying that before you make a diagnosis of Chiari malformation, you should stop and think about the possibility of SIH. Many of our patients have been either operated on or come with a diagnosis of Chiari 1 malformation, and they don't have that malformation. And let me just show you an example. Here's Chiari 1 on the left and SIH on the right, and what you can see in SIH is that descent of the third ventricle, very important. We don't see that with Chiari 1 malformation. I think we did a big review of this, and maybe 1 or 2 patients had a little bit reduction, but if you measure between the mammillary body and the anterior pons, it should be 5 to 8 millimeters. If it's lower than that, it's probably SIH. All right, so here's a patient from North Carolina. Somehow they didn't make their way to Duke. It's from a different institution. And she called me up, and I didn't take care of her, but she called me up and she said, I had this terrible postural headache, and I don't know, I was in some sort of news report, and she Googled me, and she sent me her films, and she was diagnosed with Chiari 1 malformation. And sure enough, she has pointed tonsils and a syrinx. And but I said, well, have you ever had another scan? And she said, well, funny, you'd ask. Last year, I had a branchial cleft cyst, and they did an MR on me. And so in 2005, 1 year before her diagnosis, she had a normal brain MR. That's wonderful, okay? So, normal brain MR scan, now you've got, there's no question there's not a Chiari 1 malformation. You can see her third ventricle is down. You can't even see it. It's drooped over the dorsum sella. And sure enough, she certainly has, and her veins are prominent, her dural sinus is prominent. She has SIH. So I wrote her doctor and said, she needs a myelogram and a blood patch. She said, oh, we don't want to stick a needle down there. Her tonsils are so far down. I'm worried about herniation, So what happened? She went and had a Chiari malformation operation. That did not help her, okay, obviously. And then finally, I did talk to the neuroradiologist at an institution, Wake Forest, that did the myelogram, showed the transdural herniation, as you can see here, and did a wonderful blood patch, and the patient was cured, and she still sends me little even 10 years later, little Christmas cards. So the point, I think, being is that be careful about making a diagnosis of Chiari 1, right, before you think about it. And the same can happen with myelopathy. Tonsils down. This is a patient with Marfan's. Tonsils down develops myelopathy. The person has a pre-syrinx in the cervical spine. This is caused by CSF pulsating into the cord in a patient with tonsillar ectopia from SIH. Okay, another error I see not uncommon is that flow artifacts on the T2 weighted image are misinterpreted as the dura. And so don't make this error. I don't know if you can see that, but on the left you see this little haze of a low signal intensity around the spinal cord. That's not the dura. That's just pulsatile flow in the thoracic spine. You can see it very prominently sometimes, but very subtly. You'll see it all the time. You can get rid of it by doing a 3D study or giving GAD. It will go away. But just be aware of that. On the right is the dura. You can see the dura is darker and thicker, and there's extradural CSF in this patient with a leak. So another concept they've learned is that the epidural space is a gutter. This is Dr. Fishman's term, so that a leak can quickly go ascend and descend in the epidural space. And so this is a reason for dynamic imaging, and it's also the basis of this false localizing C1-2 leakage. And what's going on here is that at C1-2 there's no ligamentum flava. So the extradural space comes up to that point and then can pour out into the paraspinous soft tissues and appear as if there's a CSF leak. I've seen several patients with blood patches up here. Doesn't work. That's not the source of the leak. It's usually lower down in the thoracic. This one was at T3-4. So we call this the false localizing sign. And just remember the epidural space is a gutter. Walter showed very early on that SIH is often misdiagnosed, and that's been our, I've said shown you a couple examples. In his wonderful article in now 2003, his early experience was that 94% of the patients received an incorrect diagnosis, and this happens very, very frequently. Migraine, meningitis, psychogenic disorders, subarachnoid hemorrhage. Patient comes into the ED with an acute onset of headache. And a third of those patients in his group underwent unnecessary procedures, including angiography and craniotomies. I've shown you a patient who had a Chiari malformation. So it is often misdiagnosed. And that's fortunately less common now, I think, because it's an entity that neurologists and ED docs recognize more frequently. But the findings can be very subtle at presentation. We can misinterpret the findings as neuroradiologists or radiologists. The CSF analysis can lead astray, and sometimes those patients are just assigned a diagnosis of migraine and off they go. And unfortunately, it can be months to years before the diagnosis is made. MR brain can be very subtle or normal in 20% of patients. Or thereabouts, and here's one example of a patient who looked pretty darn normal to me, except we saw a little extradural contrast. She'd had some blood patches that helped her a bit. She developed hemosiderin deposition in her cervical spine, in her cerebellum in 2014. She came to us. We got a study. It looked like she had extradural CSF and had a herniated disc at 2-3. And a dynamic myelogram showed contrast leaking at that particular level. And so I said to our surgeons, it's got to be the disc at 2-3. Please operate there. Off they went. They operated there. I did a blood patch. That didn't really help. Off they went. We put a little fiducial marker to make sure they know where they are. And a year later, she still has symptoms and has extradural CSF. So what happened? I was not precise in my diagnosis, as precise as I should have been. And so what I did then was another dynamic myelogram, and I showed that there was extradural contrast there. And I said, well, I'm not going to make this mistake again. So what I'm going to do is I'm going to do a fluoromyelogram. And so we're going to show you this, and I want to direct your attention right here. So she was operated on one level above. And can you make this work, or do I make this work? Click the there we go. So you'll see contrast coming up and then exiting right there. Do you see it? Boom. With each pulsation. We'll try to play that again here. I don't know if I can do it again. There we go. Watch it again. Right down. Do you see the contrast? Okay. And that was one level below the herniated disc. Okay, it was a shard of bone. So the point being that, and I sent this patient down to Walter, who nicely operated on her. Maybe you remember her, Walter. And here is the intraoperative photograph showing that small little dural defect that was causing her problems, and she's done very well. Okay, hemosiderin deposition. We see this. We see it not only in SIH, and anybody who has a pseudomeningocele over time may develop this process. Here's a patient who's been operated on for something else and has hemosiderin deposition. So it can be from a long-standing pseudomeningocele, and here's a man with cognitive slowing and SIH, and you can see that he's got extradural CSF. We did a C1-2 puncture on him and finally found a small dural rent at T10-11, but he didn't really have much in the way of extradural CSF. He just had this pseudomeningocele that was communicating with the CSF, but he had no low pressure syndrome. And so his symptoms were primarily secondary to the deposition of hemosiderin deposition. He was ataxic, he had hearing loss, and despite blood patches, he's persisted. So patients can present with memory loss, stupor, even coma, so this is our friend here. I think I went backwards here. Sorry. And here's another patient with who had sudden onset of headache while on vacation, postural initially, and then a rapid decline in mental status over 3 weeks. He came to us stuporous, increased tone, and extensor plantar responses. So in this setting, our job is to get more CSF volume, to get some volume up, to get him out of this process, then decide where we can find his leak. So in this case, we actually put a lumbar drain in and an intracranial pressure monitor and slowly infused saline over the course of 5 hours. And here you can see the lumbar pressure on top and the intracranial pressure just beneath it. And then at 5 hours, they equilibrated. He woke up, his pupils became reactive, and he persisted in normal mentation. And then we sought the source of his problem, which was a high thoracic leak, and he responded nicely to a 10 ml blood patch at T4. He was discharged home. He gave Marine World tickets, that's where he worked, for everybody except me, which is the story of my life as a neuroradiologist. Okay? Why does a blood patch fail? There's a number of reasons. It doesn't get to the site of a leak. There's a pseudomeningocele, so that there's a ventral defect that then is not covered with blood. Sometimes I have to put a needle into that pseudomeningocele and try to get blood there, and sometimes it just goes to surgery. There's also transforamental leaks that don't respond to blood patch very easily unless you take a CT approach like we would for a nerve block. It requires careful transforamental blood patching. Oftentimes this is done under sedation because it might be very painful for the patient. And then I would say the bane of my existence now is the patients with this syndrome who I can't detect a leak on. And there's a series of them that I have. They're very frustrating. We've done multiple studies on them. We increase their pressure. What are we missing? It might not be SIH, as we heard this morning. Or it could be a very intermittent or slow leak. Perhaps there's a leak that's tamponaded by the spinal cord or nerve root, which we can see, and that might intermittently be causing a leak. We may be missing a subtle venous or lymphatic fistula. Or, as we heard this morning, and I believe this is true, there may be patients who have a reservoir type of syndrome where the compliance of the dura gradually gets to a point where their hydrostatic pressure is lower, as was pointed out so nicely. And if any of you are old, you know that you get wrinkles and your collagen goes away, and my collagen's gone away, and maybe this is the reason that we see in some of these patients who have dural defects that there's just aging elastin and collagen fibers may cause an increased compliance of the spinal dura. I don't know. When we're doing dynamic myelography, and I think I'm over the time frame now a little bit, so I'm going to move on very quickly here, but we've been using a hover mat folded over on the CT scanner to increase the patient in the Trendelenburg position and then decreasing it during CT scanning. And this has worked very nicely. Other people use a sponge, what have you. The only problem with that is it's kind of hard to measure pressure there. So we measure the pressure in all of these patients, and I'd encourage you to do so. The opening pressure, if it's low, will increase with saline to 20 or 25, as I mentioned, and then give contrast there, and then sequentially scan the patient at least 3 times, up, down, and back up in the decubitus position. I like to see that so that if there's any subtle leak, I can see it's changing over time. Okay, and here's just one example of a patient who I took care of, who definitely had SIH. He had an opening pressure of 5. I could not find a CSF venous fistula in his one large perineural cyst at T7-8, filled with contrast, but I didn't see it. I did a targeted blood patch. He didn't get much better. I then brought him back and increased his pressure to about 25, 27 centimeters of water, then gave him contrast and was able to make the diagnosis of a CSF venous fistula. So it's just an example where sometimes raising the pressure may be helpful in some of these patients that you don't see a fistula. Another patient with a Chiari malformation, quote unquote, has a fistula, and beautifully shown is a CSF venous fistula. And I just want to end with the last 2 cases. I think they're kind of interesting. This is a little girl who's now 19. I just saw her the other day. She had a Chiari malformation operation at age 2 for quote-unquote headaches. I guess one of her first words was, "My head hurts, Mommy." And what happened was that she had SIH, and she also had a syrinx, you can see, and she had vanishing disease of Gorham, which is a hemangiolymphangioma syndrome. Genetic syndrome occurs in various parts of the osseous structures. And in her, she had a rapid CSF fistula to a lymphatic malformation, which was cured with our neurointerventionalists helping me put in glue into this little spot. So she's done very well, and now has presented back with headaches that are occurring, and she has a persistent fistula at different locations into the lymphatic structure. Not quite as rapid as this, but very, very slow. And I'll just show you this one other case I just took care of, this little girl with Kaposiform lymphangiomatosis. It's sort of a very rare lymphatic malformation that goes through different parts of the body. You can see it's in the spleen and in the liver. And she presented at age 2, then at age 9 developed headaches, and she has a lymphatic fistula as well. And here on the right side you can see contrast going ascending through the thoracic duct. So it's these are unusual cases, but it brings to mind that there are lots of lymphatics in the dura and around the dural sleeves, and these may be a source for those patients who have SIH that we can't identify. It's just something to think about. And then rebound hypertension, very briefly. This is a good sign from my standpoint when someone gets a supine headache after what I do. That means that their pressure is increasing, and I like to see that. It certainly is usually responding to acetazolamide. So that's a little bit of a thrill through my 30 years. I can say that it's been a wonderful time for a career to be involved in this area. It's not easy, and like many of you, we're learning more each day about these diseases. Thank you very much. Appreciate it. Thank you, Walter, for inviting me.